So hello and welcome.
Hi.
Welcome to Physician Spotlight. My name is Carolyn Newberry, and I'll be serving as your host today. I'm here with Dr. Shirley Paski, who is the director of the Small Bowel Diseases and Nutrition Program at Cedars-Sinai in Los Angeles. I'm very excited to speak with her about her experiences in nutrition during this Physician Spotlight. So Dr. Paski, thank you for joining us today.
Thanks for having me.
I wanted to start by asking if you just wanted to tell us a little bit about yourself and how you came on the role that you're in right now.
Yes, so I have a pretty strong background in nutrition. I was always interested in nutrition, even did my undergraduate and a master's degree in nutritional sciences before going to medical school. And then during medical school and residency, I took more opportunities to learn about nutrition in health and disease, and also nutrition support. So I had a unique experience where I rotated on a nutrition support team rotation, and also had the opportunity to see outpatient nutrition, multidisciplinary nutrition management clinics. As an undergraduate student, that was with Donald Dirksen at the University of Manitoba. And then I went to the University of Chicago with the intention of studying inflammatory bowel disease and nutrition. Actually, I had a mentor there, Carol Semrad, who's well known in nutrition support circles, who really was highly influential on me as far as exploring the role of nutrition support, as well as small bowel diseases, things like celiac disease, malabsorption, short bowel syndrome. And her experience and her career really resonated with me. And so after I finished that, I ended up actually in practice at the VA and the University of Washington for 5.5 years, where I had a small celiac disease and small bowel clinic, and also started the nutrition support team at the VA hospital there. And then the opportunity came up at Cedars-Sinai Hospital, which is a very large institution, to start a small bowel diseases and nutrition program here. And so we've basically modeled it very similar to the way I trained in fellowship, with both inpatient and outpatient nutrition support, treatment of small bowel diseases here. And that's where we are now, growing from a team of one, which was me and some temporary help. And now we've got myself, two dietitians, a nurse practitioner, a nurse coordinator, scheduler, and all the rest. Looking to hire actually a new physician as well.
That's great. And it's so interesting to hear about your journey, and it sounds like it started very early on in your undergraduate career. Um, how, if there are people still in their training, whether they're, medical students or dietitian students, or still doing some of their clerkships, how would you suggest, if nutrition was an interest to them, for them to actually get those experiences?
You really have to seek it out. I think seek it out through mentorship, and seek it out at a variety of institutions. One thing for me, because I trained in many different places and I've worked in many different places, I've seen that things can be done more than one way. And so it's actually been helpful for me to develop my own practice, to have that variety of experiences on the, very strong physiologic, basic science background that I had even before medicine.
Right. Absolutely.
Yeah, because there aren't very many of us that do nutrition and nutrition support. And so it's best to seek it out in the discipline that you're in. So, for example, people in internal medicine and gastroenterology with an interest in malnutrition would probably come in my direction. Other people are more interested in things like bariatrics, and they may want to go down another route with somebody who's sort of more trained in the bariatric area. And people with critical care or endocrine, there's a lot of different ways to approach it. And I think ideally, you've got a little bit of inclusion of other mentors in areas just a little bit outside of your specialty, but then a main focus of people that are in your specialty too.
Yeah, and I think that, everyone we've spoken with always, the mentorship aspect of it always comes into play. I actually had the opportunity to speak with Dr. Semrad as well a couple of months ago in this interview process, and she had very similar things to say, sort of being later in her career. Are there any other people? I know you identified her as a mentor. Is there anyone else you feel like really shaped where you are right now?
Yeah, I think definitely, Donald Dirksen, he's at the University of Manitoba. And then I had good interactions with Charles Bernstein, also at the University of Manitoba, certainly for inflammatory bowel disease. Um, and that helped me out a lot as far as just like seeing what's possible with a good database and working and collaborating with other people. And then my team is actually based on a model that I experienced actually way back. This is before I even started medicine. I was working in an HIV clinic, which was a multidisciplinary clinic providing comprehensive HIV care for women and families, which is a little bit of a different population than the gay male population that was much more prevalent at that time. And seeing what's possible as far as when you provide comprehensive support, um, with everyone from a dietitian, nurses, social worker, gynecologists, pediatricians, et cetera, ID specialists, of course, and then including the research component with the clinical care and seeing the outcomes of what happened there was very inspirational, and is sort of a model that I seek currently as far as like trying to identify social worker, psychologist, and all of that stuff to help out with our team too.
Yeah, and I think, I mean, that's another common theme we've heard, sort of that multidisciplinary care, and obviously that's Aspen's model of trying to pull from all these different specialties, and we're even trying to define who should be part of a nutrition support team, in these spaces. And so
Mhm.
it's interesting to hear about your team. What do you think has been the biggest challenge to make a program from a single person to, the large team that you're now running?
Yeah, challenge wise is often with administration. Um, and, the patients that we work with, particularly in nutrition support, and, it's really unfortunate that it has to be like this. But, the payer mix isn't, optimal from a reimbursement standpoint. And, I think from a socialized health system, I truly feel very strongly about providing high quality healthcare for people, regardless of their insurance status, and trying to find the opportunities and ways to include those multidisciplinary aspects where they wouldn't normally be covered, from an insurance perspective. And making sure that our patients do have access to those services, but that involves sort of negotiations with administration, and also seeking out sort of creative opportunities to collaborate with other people where we can share resources as well.
Right. So much of it is the business side of building the clinic. And you
Mhm.
really have a unique perspective because you trained in Canada, and you're here in the US. I'd love to hear more about some of the differences you've noticed, like between working in the two different countries.
Yeah, I mean, I was a resident. I was always a trainee in Canada, so my perspective is sort of skewed from the trainee perspective. But having a sort of more socialized healthcare system, the limitation on who could go home on TPN was more uh, the ability for the program to be able to accommodate that number of people. And there's a set amount of resources, and can that set amount of resources accommodate people? And if they can't, then the patient would go to a nursing facility, for example, or stay in the hospital until the program could kind of adapt and accommodate them. Whereas here, there's a little bit more, there's the expectation we will accommodate them, but it would be at the expense of the patient if they can pay or not, and if they need to go to a nursing home if they can't pay. So it's a little bit different in that regard, as far as like just the discharge of patients and who's able to go home in that setting, and what the program can accommodate.
Yeah, no, that makes a lot of sense. So pros and cons, obviously, with both both system and figuring out how to navigate
Hmm.
internally. What do you think the biggest, I mean, I asked you about the biggest challenge of building your program at Cedars. What do you think the biggest challenge facing nutrition is right now? And for all of us, more junior faculty sort of trying to build a career within the space?
Hmm. Yeah, I think nutrition is a field where you really have to, it's nice to be able to find your niche. So I specialize in GI disorders and associated malnutrition related to GI disorders. And that was sort of a conscientious choice on my part because you can get really broad really fast in nutrition. And going down the obesity route, which a lot of people in GI go down, is a path that, even though, to be honest, I feel quite comfortable managing obesity and related metabolic disorders, um, to avoid losing too much focus from a clinical standpoint. That's sort of the biggest temptation, is just to go everything nutrition and everything broad. But then you lose a little bit of focus in what your niche is and what your specialty is. And it even comes down to the best way to train your staff and everything, um, to be able to focus on one thing at a time. And maybe we'll broaden out to that in the future, but it would probably be with, another provider to kind of fill in that niche, and then hiring additional personnel as well that can kind of really focus and hone in on that aspect.
Yeah, that makes a lot of sense. It's definitely something I've been thinking a lot about, trying to be a more broad nutrition based clinician, but probably will have to subspecialize at some point.
Yeah. Because
Um,
there's so much, like, as far as, like, do you want to choose like more like specialized dietary therapies for diseases like celiac disease or eosinophilic GI disorders? And I do have a good number of patients with those sorts of diseases, just because I have the dietitian access included in my clinic. Um, or the malnutrition, but I've just stayed completely away from obesity because that would really overwhelm the program, I think.
yeah, that again makes a lot of sense, because obviously there's limited resources and limited time for everybody.
Hmm.
Um, any particular research interests you're pursuing right now, like within the clinic or with collaborators at Cedars or other places?
Yeah, I would say most of my work is collaborative at this time, just because my clinical load and building the clinic and the patient population and everything has been very heavy in the last few years getting this up and running. And so we have a few projects, mostly related to short bowel syndrome, um, collaborating with other providers. We did a phase 1 trial looking at GLP-1 agonist for the management of short bowel syndrome that wrapped up last year, doing some patient-related programs and data extraction from internet patient sort of support group type information with our health services research group, collecting tissue, of course, from the small bowel in my small bowel work, and then some other registries and prospective databases as well, especially looking at geriatric patients on TPN.
That's great. And I'm sure, more to come from those different topics. And definitely shortcut is, I think, a ripe area for
Mhm.
research. I wanted to thank you so much for sitting down and speaking with us and the Aspen community. I don't know if there was anything else you wanted to add for our listeners.
Yeah, I think the big thing is, if you're interested in nutrition, go for it. This is truly a growing field that needs good science and good clinicians to marry the science and the patient, and also taking into consideration patient factors. Um, and I would say that I've been much more philosophical about it, and working with patients and their ability to adherence with the treatment objectives and outcomes, and become much less prescriptive in the sense, and acknowledging that when in the field of nutrition support, nutrition and what we eat is so much married into our culture and society. And many of our patients on nutrition support are unable to take part in that. And so when we have patients on nutrition support, like we really want to make a lifestyle that they can work with to the best of their ability. It may not be perfect, but we want to enable them to have as much of a normal life as possible, and to get the most out of life given their circumstances.
Yeah, and I think that's a great closing statement, and something that I'm sure all of our members aspire to do for their patients. So
Mhm.
again, I wanted to thank Dr. Paski for joining us today, and I'd also like to thank Aspen for their partnership for this forum. Have a great month, and we hope to see you next month.
Thank you. Bye, everyone.